Okay, so my name's Jackson Bartlett, ACP with the Queensland Ambulance Service, doing a exemplar video presentation as part of PAR 4440 on intraosseous Easy IO for drug and fluid administration. So I'll have several parts of the presentation. Firstly, I'll describe the Easy IO Easy IO gun that QAS uses. I'll use their indications according to the QAS landmark sites. And also I'll give you a practical demonstration of all our landmark sites that we use, finding those, and then finally I'll give a practical demonstration of Easy IO insertion into a chicken leg to aspirate blood, bone marrow and show the technique. QAS indications for intraosseous drug administration is emergent access for administration of drugs in the fluid when IV access is unable to be obtained, contraindicated for known bone pathology, fractures distal to the limb or fractures of the limb or fractures above the insertion site, and other bony pathology such as osteogenesis imperfecta. And at all times we should avoid sites where there's burn cellulitis above the actual insertion site as well. So complications of intraosseous administration include infection, extravasation, damage to the apical bone plate fractures, and also the introduction of air embolus. So the QAS utilises 3 sites. The Easy IO website actually states that there's 4 sites of Easy IO insertion. The proximal humerus, distal femur, proximal tibia and distal tibia. QAS doesn't use the distal femur as a site of insertion. We're limited to 3 sites. So starting distally, we'd find the medial malleolus, which is a bony prominence that you can find just above the ankle. We want 2 centimetres superior to that and across the tibial plateau. So we would mark our insertion site with a marker and a short aseptic technique. Insert. So we find the medial malleolus, 2 centimetres superior, and on the tibial plateau. There. In terms of our proximal tibia, we would find the tibial tuberosity, which is a bony prominence just below the patella, which can be palpated in this patient approximately 2 centimetres below the patella. The insertion site is 2 centimetres distal and medial to the tibial tuberosity, so approximately there. In terms of our humeral head, I won't get my patient to take his shirt off, but what we want to find, we want to first of all ensure that we've found the greater tuberosity of the humerus by, if possible, without causing too much discomfort and pain, moving the patient's arm, pronating until you can find that you're not on the acromion process, that you are actually on the humeral head. Once you've located the humeral head, we either pronate the arm forward or we fold the arm across the patient's chest, abdo, which rotates the humeral head forwards. Using the palm of an open hand, embed the humeral head into the palm, and then inline axial direction, follow up the humerus till your fingers intersect, and 2 thumbs right should put you straight over, slightly anterior of the midline of the humerus on the greater tuberosity. The preferred site of administration according to both the Easy IO website and also the QAS CPG is the proximal humerus. The rationale being that it's above the diaphragm, so it's feeding the inferior vena cava as opposed to the superior vena cava. Superior, vena cava. It's also less likely to be, in the event of a severe trauma where you potentially have pelvic involvement. Venous return is not compromised by inferior trauma in traumatic patients. It has a higher flow rate than the other 2 insertion sites, and I'm also, from reading the Easy IO website, potentially is less painful than the tibial insertion, and as a result that becomes our preferred insertion site with the QAS CPG and the Easy IO website. If we are going to go with the humeral head, the humeral proximal humerus insertion, I always want to maintain that we will maintain immobilisation of this limb in the event that if an accidental movement occurs and the arm is anteriorly raised, you can actually cause damage or snap the IO needle on the acranian process, which we don't want to do. So we'll always make sure we isolate that arm with either a bandage or... Okay, so I'm going to demonstrate the insertion of the Easy IO using a 25 gauge needle into a chicken thigh to show you the technique for insertion. So first of all, we safely remove the sharps cover, ensure that the needle is securely located onto the IO gun. We've got our pre-primed fluid line, 10 mils of saline for a flush, our sharps container, an opsite to maintain sterility, and some tape to secure it once we've inserted it. Ensuring that I've got safety glasses and gloves. We've swabbed our receiving site. Aseptic technique. Once we've located the landmark, as I explained earlier, we're going to insert the IO gun at 45 degrees, pressure downwards until we meet resistance. Safety check, ensure that the 5mm indicator marker is visible above the tissue. If that is, we then apply gentle pressure downwards until loss of resistance. Once we've found loss of resistance, remove the gun. It's a solid insertion, like a nail in timber. I'm going to remove the drill into the sharps container and dispose. Going to add our extension line. Once we've added the extension line, we aspirate backwards with gentle traction, looking for the presence of blood or bone marrow, which you can see we've got in the line, confirming that we're into the medullary cavity. We then, if it's an unconscious patient, flush fluid into the medullary cavity to ensure we've got patency. It won't be discussed in this video, but in the conscious patient it's appropriate to give some anaesthetic, such as lignocaine, as a flush due to the pain that can be caused by flushing fluids into the medullary cavity, particularly in the tibial insertion. Once we've confirmed patency, we then secure the insertion site with an opsite, just to ensure sterility. So this is an example of an appropriately secured proximal humerus IO site, opsite over the IO needle to ensure sterility and stop foreign particle ingress around the insertion site, and then with the actual giving line also appropriately secured so that it can't be pulled out if the patient's moved or if it gets caught on anything. Just to reinforce what we were talking about earlier, particularly with a humeral insertion, we want to immobilise the arm to prevent superior rotation of the arm against the acromion process, which can cause either damage or snapping off of the IO needle.